I should have, I mean, hold on. Let me just go back to my preferences. Uh, if I go in here, says cannot use accessory because it uses too much power. That's so weird. I literally just had
Oh,
this all. I
so
literally just
you're
had this all set up.
did you go to CMCC or where'd you go to school?
UWS
Okay.
back in the day, WSCC, but yeah, Western States.
And then are you practicing where you're from originally, or where are you from?
I am from Victoria, BC. So it's on Vancouver Island,
Hmm.
just off the west coast of Canada. So just west of Vancouver, basically. Yeah, born and raised here. Spent my whole life here, except for when I went to UBC in Vancouver, and then Portland for EWS.
Do you have like a typical chiropractor origin story, or how'd you get in the field, or why?
Yeah. I don't know if it's typical. It probably is somewhat typical. So I herniated a disc in I would have been 19, just like probably 19 to 20 years old in that range. And it was pretty acute, man. Like I couldn't even weight bear on my left side, had like electrical pain down my leg, had pretty significant calf wasting within like 6 to 8 weeks. And I had seen a few different people and a kinesiologist who I had mentored with in my high school co-op. He suggested that I actually see a physio, and the physio was from New Zealand, and he actually kind of practiced more like a chiro. Like he lays down some pretty good adjustments, and he just fucking like dropped on me, man. Like just, and I mean, it wasn't a painful adjustment at all. In fact, I at that point had been about 8 weeks out and still unable to weight bear on my left leg without like shooting pain going down my leg. And he did like it would have been a right-sided lumbar roll and a pretty like hard like traction adjustment, like just yanking on my leg pretty much. And I walked out of there, without that shooting pain, and that was a huge turning point for me in terms of that kind of like acute phase recovery. And he adjusted me probably two or three times and then transitioned into rehab. And I really didn't get that much better with the rehab that I was doing with them. So
Huh.
then I ended up going to see, a couple different people over the years. Mike Murray, who was like an active release chiropractor out of Victoria, BC, kind of one of the first guys in Canada doing active release technique. And then one of his associates who was, I would say, just younger, keener, more thorough, did a pretty good job with me. And again, I was probably at like 80%. And I was just like pretty impressed with the clinical reasoning process that one chiropractor kind of employed with me. Like he was, his diagnostic reasoning, how comprehensive and thorough he was impressive to me. And then I kind of plateaued at like 85, 90%. Like pre-injury, like I was, front squatting 300, back squatting 350 kind of thing. Like I was reasonably strong. And I was kind of like most of the time pain free, but still really unable to load. And I ended up seeing a guy in Vancouver when I was in school there, a couple chiros actually as well, who didn't really make a big difference for me. But a guy who eventually taught for Tom Myers through Anatomy Trains. Still a good friend today, actually. Just had dinner with him actually a few weeks ago. So yeah, I kind of have multiple different like practitioners who worked with me, but those that impressed me the most were kind of those with the clinical reasoning set of a chiropractor, but they were all helpful in different ways. And so when I was pretty young, I kind of thought to myself, like it doesn't make sense to me that I need to go see three different people to get the reasoning and the skill set to get me better. Like it seemed like each person provided one plug, where I kind of felt like, why couldn't I have gotten that with one person and just, ultimately gotten better in a much quicker time frame? Of course, I don't, n equals one. You don't know what my natural history would have been or how those interactions ultimately influenced it. But my experience was that I got a tremendous amount of benefit from the adjustment in acute phase, ironically, like lumbar discogenic radiculopathy, et cetera. And then I got some benefit with like active release technique, soft tissue skills, that took me from like probably like 50, 60% to like 85%. And then I just was not getting any gains on that last 15% with active release, adjustments, mobilizations, etc. And then when I saw this like structural integration based body worker, he was able to kind of take me to being, mostly resolved. I still can't load my squats the way I did back in the day, but it's not really a priority for me either. So it's not like
Mm-hmm.
I've tried to push it, but anyways, so I mean, this is a long story, but then I go to school. I was actually in school when I saw the body worker, and I knew that I was going in the direction. I thought at that point physiotherapy, and then I was kind of trending towards chiro as a result of my experiences with my back injury, but I still was undecided. And honestly, it just came down to evaluating the curriculum in detail. So I just like had the curriculum of like physiotherapy, had the curriculum of chiropractic, looked at like sports medicine, physiatry. I knew I wanted to be an MSK specialist. I just didn't really know exactly what domain. The physiatry and sports medicine was like interesting from a diagnostic perspective, but I wanted to be the like boots on the ground, hands on. Like
Mm-hmm.
those professionals typically they diagnose, and it's kind of like we'll see you later. You know what I mean? Then they're referring out to other people who actually put the work in. And I really was quite intrigued by manual therapy and the influence that it can have over human movement. So that left me with physio and chiro. And when you look at the curriculum, chiro is just so much more comprehensive in terms of differential diagnosis. So I was swayed in that direction. So that's why I ultimately went to chiro school.
The main reason I wanted to have you on, besides just having a conversation with somebody I haven't formally met, which hopefully we get to meet in person at some point, besides virtual, was, from what you portray online and what I've heard about you and, some of the things I've read, I can tell obviously how detailed and how, I don't want to say mechanistic because that can sound bad, but like kind of in the weeds you're willing to go in a good way. But that leads to this like diagnostic accuracy piece, which is kind of at the heart of what I preach within our office walls and teach a little bit. And you mentioned that multiple times already. So as you went through school, obviously I already had this, diverse palette of what you had experienced, as a patient. And then and I agree, the irony behind, the biggest hammer as a chiropractor, got you the furthest home, after this. And then it was kind of all the other pieces that kind of stacked on top of it. But as you went through school, did your mindset change at all? Or did you kind of say, okay, I'm going chiro and I want to be boots on the ground and diagnostic accuracy is at the heart of it, and you already knew what you were doing? Or did some of this stuff get formulated along the way? And how did that play into like when you got introduced to things like, DNS and NDS, and how did that start to change your personal palette as a practitioner?
Yeah, I mean, I guess the other part of the origin story is that I was personal training when I was 17 years old. I took like a medical exercise specialist certification when I was 18. I went through the personal training certification twice because I didn't feel like I learned it quite well. Like I was really passionate about exercise, working out and training at a pretty young age. And just I knew I was going in the direction of, at that time, I thought physiotherapy. So I had done a lot of mentorship with kinesiologists. So I was very exercise based from day one. And then I also kind of saw the potential for manual therapy, especially with my individual interactions with different practitioners and the eclectic balance of different manual therapies and how they could influence different presentations. I kind of went into school thinking that the pillars of rehabilitation were exercise in all of its forms, manual therapy, and manual therapy divided into like joint specific mobilizations, manipulations, and soft tissue techniques. So that was kind of like my foundation before I even went into school. That was my opinion. That's what I thought was essential in the ideal management of patients. And, before I even went to my undergraduate studies, I was mentoring underneath that chiropractor that had treated me. So I ended up, after I got my medical exercise specialist, I actually was like assisting him as like an ART assistant. So I was, putting modalities on, putting hot packs on, helping him move limbs for active release techniques, doing exercises with his patients as he would recommend, witnessing his differential diagnostic and clinical reasoning skills. So I kind of went into my undergrad already with somewhat of a foundation, I thought, at least, for what were the key parameters for managing patients. So when I went into chiropractic school, none of that really changed. I just knew that all of it was relevant. So I don't know if you had this experience, but a lot of people, like especially in that like first year of chiropractic school, first like 6 quarters, when it's very like basic science based, they were like, oh, why do I need to know all this physiology? Why do I need to know the biochemistry? Why do you know what I mean? Like histology, et cetera. And I knew from day one how essential those things were to completing the picture in differential diagnosis. Um, so I felt like chiropractic was a really, really good education in the basic and clinical sciences to form the foundation for clinical practice. So it didn't really change, but it certainly provided, I think, the best foundation I could have gotten out of a degree to move forward.
Yeah, to say that. So I teach a course called Art of the Assessment, and this is when people say first principles approach. Some people, kind of want to almost scoff at that now because of how it's used and maybe how poorly it's represented. But the first principles within any medical practice, it doesn't matter, conservative MSK or, oncology, whatever, it is the core sciences. And I agree that for some reason in particular, physical therapy, chiropractic, it seems to get glossed over, not in terms of how we're taught. I feel like I had wonderful professors and it's what you put into it, but it's almost like we're, for two reasons, and I'd love to hear your comment on this, is we breeze over because we see like these big manual skills, patient interaction, we're going to have to go do these things. But then also like we're having to go through, and I say have to, continuing education, outside seminars from day one, MPI and, DNS, we can do all those things. So we don't see how important those core sciences are in terms of the understanding of all of these concepts. We just kind of see, well, I'm learning this stuff and then I'm going to learn how to do the things as I go that are actually important. And it's kind of, then we get into practice and you're like, you read a research article, you go to a seminar, and now you have no filter to screen these things through because you didn't, understand physiology 101 as good as you could, or histology or neuroanatomy. And all of a sudden you're like, oh, I have to go back and research. Or what I kind of find in our profession, you're much more involved in the continuing education game, is people rely on what they're told via a method or a technique rather than trying to kind of, I don't want to say pick it apart, but basically apply a filter and say, well, does this make sense? Right? Yeah, it may get a result, but why is that occurring? And can I better myself as a clinician by applying that filter? So again, I would say it's rare that you have this template. I'd say it's very rare that you're like, I had these pillars going into chiropractic school, right? A lot of us have some experience and you're like, God, I did a lot better and I'm going to go do this thing because I'm involved in sports or I like medicine or whatever it is. So I think that's rare. B, as you went through school, how, besides just kind of really honing in on those core sciences, what was the thought process behind, obviously you're not reading research at this point. You're not trying to understand like concepts you're going to use in future practice. How are you propping this up in your mind of like, I know this to be the most important thing? Because I'm assuming you're a kinesiology undergrad, so you were kind of experiencing, a vast swath, but like when you dove into physiology and all the other or systems of systems, how are you starting to frame in your mind of like, man, this is going to be important. I'm going to use this later. And I mean, how much are you having to revisit that, all of that now?
Yeah, I mean, I think a big part of that, which I feel like is super helpful for anyone who has actual experience working with people in the context of rehabilitation before they go into school, it helps you contextualize the basic science based off of clinical presentations of patients that you've seen in the past. So, like I said, I started personal training when I was 17. I did my medical exercise certification when I was 18. I was working in the chiropractic multidisciplinary office when I was 19. I had seen a lot of different clinical presentations, and I'm trying to make sense of it as I'm going through, obviously not having the rich background in basic sciences yet. But even going into my undergraduate degree and continuing to personal train, practice as a strength and conditioning specialist, I was always trying to, apply the basic sciences into the people that I was working with, whether that's a rehab case or whether that's just personal training. So I think that is a huge difference, is that we go into chiropractic education. Many of us go into chiropractic education with no experiential background. And you spend like 2 years only learning the theory before you even start to think about how you would interact and work with patients. And I feel like it's way easier to learn the theory when you have a practical foundation, because you then start to interpret the basic physiology, biochemistry, histology through the lens of the patient presentations that you've seen in the past, as you start to make sense of it all. If that makes sense. So I felt like I could contextualize physiology when I was going to school based off of people that I had seen or I'm currently seeing, because I was still working as a personal trainer. To me, that made mastering the theory so much easier. Like, to me, the basic sciences were really, really easy, not because I'm super smart, but because I had all this experiential background to apply my knowledge to. And then you're not remembering like individual pieces of facts. You're creating stories that fit within physiology and patient presentations. So that, I think that's a big difference, and I feel like we probably need to do a better job of getting people into that kind of clinical reasoning mindset from day one, so that when they're going through biochemistry, histology, and physiology, they're starting to put those pieces into the puzzle of a patient's presentation. In the end of the day, like diagnosis, it comes down to what is driving the physiology that results in the expression of the patient's symptoms. It's like Shacklock has the saying is physiology is the gateway that underpins or translates the biomechanics into symptomatology, right? In other words, like, it all comes down to physiology. Like, a person doesn't have pain unless the biomechanics has an influence over the physiology. So there's some weird mix of biochemical compounds that are activating a nociceptor or a secondary wide dynamic neuron or something of that nature that's creating the patient's symptoms. So that's kind of a cool thing to think about if you think about it. So, like, let's say you've got a patient and they have a supraspinatus tendinopathy, and you decide that you're going to do, I don't know, let's pick something abstract. Exercise is obvious. Let's say you decide to do active release technique on them, and you've changed that patient's symptoms, not in the temporary, but they report to you that 6 weeks after, they still continue to experience symptom relief. Well, you could make a story up about adhesion this and adhesion that. The reality is you're not freeing a fucking adhesion on the supraspinatus with your hands underneath the coracoacromial arch. But obviously, in that N=1 presentation, the patient reports and you've observed a change in their symptomatology. You could say it's placebo, sure. But I would argue that it comes down to the physiological mechanism, and something shifted in their physiology. Could be placebo, it could be the manual contact, could be the movement associated with the manual contact and the treatment. It could be the fact that the patient felt temporarily better, and then they walked out of their office and they used their shoulder more and loaded their tendon. Mm-hmm. But the bottom line is all of those mechanisms converge onto a change in the biochemical compounds that result in the expression of nociception.
When I saw a post you put up that, or maybe it was a blog about, this whole idea that, pain is just basically an experience, and that, we're missing the mechanistic components that underpin it, which you and I would, we'd sit around and drink a glass of wine and we'd just kind of be saying the same thing over and over to each other and kind of probably smile and be like, yeah. So I don't want to be an echo chamber, but I do want to dig in on this stuff. So I 100% agree with you. When we, even if we say, oh, it's a placebo effect, like you said, well, you had an effect, and that effect is a catalyst, right? It's almost like Schrödinger's cat, but there's a million opportunities for physiology to change. And we probably, this is what drives me nuts in practice. You never really know, right? You have a narrative that we create, and hopefully that's based on core principles of, science. But at the end of the day, you'll never be able to fully uh, basically rope in exactly what changed. Even if you had, uh, a deep needle biopsy or all these things going, like immediately you just be like, you don't know, because you don't know what the catalyst was. So let's back up for a second and dig in, because there's so much stuff there. Um, so it's almost like things were revealed to you in a clear fashion because of your experience going before you went into chiropractic school, and now you own a continuing education company. You teach, all the time. You say that we need more clinical reasoning paired with the core sciences, so it kind of does more of this revelatory teaching rather than just kind of like get in this core block stuff and then get into patient treatment. How would you do that? Like, do you have any ideas of how we could do this better in chiro school or outside of school?
I mean, oh man, it's such a complex question. Um,
And I know some schools are trying to do this, right? Like
yeah,
earlier trimesters, they will have a clinical reasoning class, but they'll have different phases. So at Logan, you now have clinical reasoning instead of just try six. I think they have 3 phases of it, right? So they're trying.
I think the strength of medical school is that they're literally in clinical rounds from day one.
Yeah.
They're running through exams within the first like few months of school. Like I had a patient who he's kind of on the tail end of school now, but he's probably year 4 or 5 now. But I've been seeing him off and on for years, even before he was going into school. And I remember chatting with him about, how's your school going? Like, what are you doing? And just kind of, inquiring about the program and where their emphasis is. And he literally was examining patients within like 4 months.
Mm-hmm.
Man, that's a huge strength of medical school, because they're already forced by the virtue of having hands on a patient and doing an exam, to think about, well, what the heck is going on in this patient? That I always say, like, the patient imposes clinical reasoning on you.
Mm-hmm.
You know what I mean? So the second you have a person in front of you, you have to start thinking about, okay, what is going on with this patient? And it's those questions that take you through the rabbit hole. You know what I mean? And that's really what we need. Is we need the rabbit hole. We need to continue walking down that rabbit hole with every single patient to kind of funnel our way down into something that makes sense. So, in present day, I think we have a couple ways to do this. I think that the phenotyping of a patient's presentation and a patient's physiology is super important. So, we've got Annie O'Connor's book, who, she wrote on nociceptive, inflammatory, ischemic, nociplastic mechanisms. And then she had cognitive, affective, social. I think she has social in there, right? Did she have social as a
Social is
separate?
part of effective. Yeah.
Yeah,
Yeah.
right. And then you got neuropathic, right? So, in Walton and do you know Dave Walton and James Elliott?
Mm-hmm.
Yeah. So in their book, I kind of like the way that by the way, I love Annie. I think she's amazing. I think her book was revolutionary in our profession in terms of getting people thinking about the phenotyping of patient presentations and how that shifts how we interact with them. However, I do think that there was a mistake made in the terminology used, in that they're not actually pain mechanisms. There's no such thing as an affective pain mechanism. There's
Mm-hmm.
no such thing as a cognitive pain mechanism. That's not a mechanism. That's a potential driver. That's a potential influencing factor over the patient's pain presentation. It is not a pain mechanism. There's
Wouldn't you?
ultimately,
So can I pause you for a second? Wouldn't you
yeah,
agree though that the way that Annie explains effective, right, is that you have one of the preceding 3, right, ischemic or and then you have an overlying emotional or social factor that then brings it to effective. So the mechanism is kind of cooked in. Am I wrong on that?
yeah, I feel like seeing Annie talk in person and reading her book, I don't think that's clear enough.
Okay.
I think it should have, the terminology just should shift entirely away from a pain mechanism, Because to me, when I read that
Okay.
book, and to me, when I hear Annie talk, is that she's describing these things as mechanisms, but they're actually drivers.
Yeah. So you're saying it's the not necessarily the semantics, but the categorical breakdown that if you broke them into effective, that now we could somehow, if maybe we're not being super aware of like the whole picture, just say, oh, it's effective, and then bypass the mechanism that got them there that could still exist or maybe doesn't at this point.
Yeah. Yeah, I think, well, I posted on Facebook the other week that I feel like one of the most damaging phrases that's come out of the pain science world, which I think it's probably damaging to even call it pain science. It was a statement made to the effect of, and you can correct me if I'm wrong here, and we can probably Google it to make sure I don't get this wrong. But I believe the statement is nociception is neither sufficient nor necessary to cause pain.
Mm-hmm.
And I think that is factually inaccurate.
Mm-hmm.
And I think it's incredibly damaging to the psyche of a clinical practitioner and the way that they engage clinical reasoning. And it creates this, essentially this out, like, oh, well, if nociception is neither necessary nor sufficient, then I don't really need to worry so much about nociception because it's probably just, something in the psychosocial realm,
Mm-hmm.
right? Even when that might be a very apparent influencing factor over this patient's presentation, and very apparent that you need to work through their emotions and their cognitions, the feelings and thoughts that they have about their current situation, and potentially social factors as well that might be influencing it too. You still have to make sense of how those things are influencing the nociceptor apparatus. And I think what probably is more likely than not is that you have a nociceptive driver that has an overlay of, 3, 4, or 20 other things that make the nociceptive driver persist.
Mm-hmm.
And nociplastic pain is probably a little bit of a different bucket. And I think we're living on a big continuum where if you have anyone with chronic pain, regardless of the degree of nociplastic mechanisms, there is going to be adaptation of the nervous system that's going to likely amplify the sensitivity and the presentation of that patient's pain.
Well, even the phenotype of the person coming into the scenario of the mechanism, right? Which we know, all the way from collagen distribution to psychological phenomena, but I think at the heart of this is, correct me if I don't want to put words in your mouth. We can't categorize a person. We're a complex organism. And again, we can't put somebody into one of the 6 categories of pain because they're never one of the 6. It's always a combination or a percentage that, oh, it's 10% ischemic, or it started there and now it's 30% effective. And, or look, there's a little motor autonomic, but it's not, textbook. What I tend to see in particular with like new grads and interns, this isn't a knock, but I think it was popularized, as you said, as like an out of, it's almost like we would treat people in a mechanism or mechanistic fashion, right? Pathoanatomical. When that failed, it became, which is such a terrible use of the terminology, a biopsychosocial case now. And it's like, well, what are we talking about? Like, it's always biopsychosocial, and it's not that we go from treating, the physiology of the person and realizing, oh, it's a non-physiologic, oh, this is a no. In my opinion, I just think that got like overplayed, and it's not moving into that realm. You're treating an organism, which is a conglomerate of all these things. And that's, to be honest, why our job's kind of tough. It's much cleaner to say, they're in this category, we're treating this specific thing, and then we have this cookbook play. That, as well as I do, that's the whole reason that we say N of 1, like that doesn't exist.
Yeah. Well, and the other wrench that can be thrown into it is that sometimes maybe none of it really matters because the person has a biological predisposition for, a nociceptive system that goes awry. I don't think we have direct mechanisms to treat that specific dysfunction yet. I think the answers will probably lie within the the pharmaceutical industry and the biological sciences that underpin the specific biochemistry that drives that system. And there are some things that are coming out now that are making some changes in that realm. But I think that the reality is a lot of times our interventions are indirect. Well, not a lot of times. They're always indirect mechanisms into a complex physiology that manifests itself as pain. So you're right that yes, there is always, an element of all of it. I don't know, neuropathic would be a good example of that, however. So listen, if a person has pain, there's activation of the nociceptive apparatus. That's clear, So if they have pain, there's activation of the nociceptive apparatus. It might not be a neuropathic mechanism. Neuropathic specifically meaning that's something that's affecting axons and dendrites and cell bodies. And sometimes it's neuropathic nociceptive, whereby it's the nociceptor within the nerve that's causing the pain presentation, which then gives you this weird category where they have a nociceptive pain presentation, but it's a nociceptor within a nerve, i.e. the nervi nervorum. So it's in Walton and Elliott's book. I personally feel like they said neuropathic has a nociceptive mechanism, but you would treat it as if it's neuropathic, and I disagree with that. I think you treat nociceptive pain that is within a nerve like a nociceptive mechanism, which means try to address the nociceptive driving mechanism, right? What is compressing, irritating, inflaming, or sensitizing this nerve? And that doesn't need to involve pins, needles, tingling, radiating pain, electrical pain, etc. It could be just a classic deep, dull ache that is very similar to something that would be quote unquote plantar fasciitis, but it is not. It is the nociceptors within the nerve, i.e. the medial calcaneal nerve, that cause that deep, dull ache that results in pain when they load their plantar fascia first thing in the morning. But then as they move around, the shifting of physiology and the biochemical components of that tissue is spread through, and you get better molecules coming in, and they don't have pain anymore, right? So, and then you have, central nociplastic. Again, like I said, you probably always have an element of sensitization in chronic pain patients, but perhaps not on necessarily the acute pain presentation. That's maybe irrelevant. But then you have cognitive, emotional, socio environmental, and sensory motor disintegration, right? What I would say is that, yes, everyone has a social factor, everyone has an emotional factor, everyone has a cognitive factor, but they might be completely irrelevant to the resolution of their pain. So you need to see those things. You need to observe those things. You need to make sure that you're screening for the potential risk factors that might be at play, but they might be totally irrelevant to the resolution of that patient's pain. Like I'm sure you've seen it where a patient comes to you. They've been to 8 different practitioners, including a pain specialist. They've been thrown in the biopsychosocial bucket, which really means the psychosocial bucket. They're basically telling them that, listen, this is, it's not really a problem with your back. It's just this, nociceptive apparatus gone awry, and now you have what's called nociplastic pain. And we feel like you need to manage your emotions better. We think that if you think about your pain a little bit better, and you maybe help address your relationships and social environments, maybe you can walk your way through this situation to a better outcome, which still means you have chronic pain. And in those patients, I've identified very clear nociceptive drivers, address those drivers, and the patient's pain resolves. After years, like 6, 7, 8 years of chronic persistent pain and literally doing nothing, not talking to them, not changing their thinking, not changing their emotions, not changing their social environment, just changing some specific mechanism that's, for example, loading the nerve at the interface of piriformis. Something as simple as that.
Well,
right?
God, there's so many freaking veins we could go down. I wanted to point this out. So, this is no knock on Benjamin. So your counterpart with somatic senses. So when I did an interview with him, we were kind of going down this rabbit hole, right? We were talking about, peripheral nerve, cutaneous nerve sensitization, possibly leading to trigger points. And then kind of thinking about these like mechanisms and what that does to change your treatment. but then also of how that curiosity of, well, what's, like what started this? What's actually happening? What, like you said, like there's a mechanism that may have preceded this that still is occurring that's now absent, and we've kind of shifted, departments. But Ben kind of came back at one point. He goes, it really doesn't matter. He goes, what we want to do is, when we get people out of pain, we want to get, positive movement experience, get them moving. That's the goal. And I was like, but then that leaves a giant gap of like the betterment of you as a clinician and the betterment of the profession, in my opinion, right? Because if we don't ask those questions, I mean, what do we, what's a researcher doing? Where's the theory come from? What do we explore? But what you're also saying is you're also, it's not being left on the table for research. It's being left on the people that are basically the left outs, right? 6 to 8 years of being told that this is, non-mechanistic, or it's outside of the realm of typical, conservative musculoskeletal. And you're like, maybe not. Maybe we've just kind of missed these, maybe poorly understood, poorly observed, probably a little bit of both. So this gets at the heart of, again, why I wanted to bring you on here. Of it seems like you talk a lot in your articles, and what you teach is about diagnostic accuracy, which gets down to these core sciences, understanding the principles that then prop up all of the methods and techniques and everything that we're doing from a hands-on approach. So when we're looking at this, how for students that are in school or new grads or docs, because that's probably most people that are listening to this, let's say they are, obviously we all know about this. We learn core sciences. If you graduated, it's being talked about. But let's say people are kind of just skipping along through practice. They're applying methods, they're applying techniques, they're going through an exam, but it's kind of, maybe it's not the flying seven, but it's kind of the same thing, right? Or we're not questioning. How do we kind of put the, a break on and then say, well, this is what I need to start, paying more attention to or looking at, or is there some sort of gross process? So we talked about this, clinical reasoning in school or early on in, the profession. But if we're already in practice, how do we kind of say, I have to start paying attention, and what do I pay attention to? Because it sounds like we're just opening up Pandora's box of God, everything that's possible can and will happen. And some of the things you're learning are probably not right. And the things that we're doing, we don't even understand what's happening. So you can understand the daunting, like, for a student or somebody.
I think the thing is that we do have, science has elucidated mechanisms of many things, just not all things. Where it can't help you is defining the mechanism of an individual patient. But we do know, with, I think, reasonable, accuracy, the mechanisms of manual therapy. Will we learn more in the future? Yes, we will. But I think we have a reasonable understanding of the mechanisms that underpin the effects of manual therapy. I still think, by the way, there is one group that still says that the mechanisms of manual therapy are global in nature, contextual in nature. But, if you look at Stecco's work, I think there's also, and Beau's work, I think there's also clear indications that you have changes within the local tissue as an outcome of manual therapy as well. So I think we have known mechanisms for manual therapy. Listen, we have like thousands and thousands and thousands of studies on exercise, and not just like, specific mechanisms of loading, but also, just cardiovascular, physiology, etc. So we kind of understand how exercise works. Which is obviously complex and comprehensive, but we have a pretty good idea of how that works. And we have a pretty good idea for the set of assessments and mechanisms that can contribute to a patient's pain presentations. And it just comes down to something as simple as, how does this movement load all of the tissues in area X, Y, and Z? So give you an example. If we go into multi-segmental flexion and we bend down, we touch our toes, what are all of the mechanisms at play when we do that thing? Well, you have sensory motor control, or motor control mechanisms that influence the lumbopelvic hip rhythm. You have the control mechanisms that influence the coordination of diaphragm, pelvic floor, abdominal wall, i.e. intra-abdominal pressure mechanisms, and how that pulls them through a flexion mechanism. You have the eccentric activity of the paraspinal muscles that goes EMG silent at the end range of motion. Note that's superficial erector spinae, not the deep rotatories multifidus. You have the elongation of the nervous system. So the entire nervous system from the spinal cord and the brain all the way down to the toes is elongating. And while it's elongating, it's also sliding. And the sliding mechanisms change depending on the range of motion. So the first movement, if you do a true multisegmental flexion, if I look down and I curl through my spine, what's the first movement of the spinal cord? It goes up, right? But as I transfer that movement down into my lumbo-pelvic hip mechanism, it pulls it back down, and eventually it doesn't really move that much because you're tensioning in both directions, right? So you go from a cephalad slider to a caudad slider, or proximal and distal slider relative to the lumbar spine, into a tensioning mechanism. And that tension is transferred through the entire system. That makes sense? Mm-hmm. You have opening of the facet joints. You have elongation and tensioning of supraspinous ligament, interspinous ligament, ligamentum flavum. You have opening of the posterior disc and elongation of the fibrocartilaginous fibers of the posterior annulus. You have compression of the anterior annulus. You have a posterior migration of the nucleus, which, by the way, is normal and healthy in this situation. And you have compressive mechanisms which load the disc, load the nucleus into the posterior annulus.
Well, can I stop you for a second? So yeah. I'm assuming, and this is why I want clarification for those listening.
Yeah.
Being aware of all these mechanisms that are occurring, right? Let's just pick like a few, like the cephalad sliding of the spinal cord in the first portion of multisegmental flexion. I'm assuming is important to you because if somebody's going through this gross motor movement, right, that is probably not a great audit if we're trying to be specific, but if people present with like movement aberration or pain in these parts of the movements, or you can already have suppositions, right? And divergent thinking is this mind explosion of like, like that's kind of interesting that the pain gets better as they go further into the movement or gets worse. Or am I right or wrong on that? That is, all of these things are occurring in your mind from a mechanistic standpoint still, that you're like, I can have hypotheses that now I have to crush while I kind of stack testing. And by the time I'm done with my exam, based on my understanding of anatomy and physiology and all these things, you're like, yeah, this seems like the most likely. I bring that up because, I'm not trying to be mean to the profession. 90% of the profession is not thinking at that high of a level of the mechanisms of like a gross motor movement.
Well, yeah, but so I'm going to take this further. So just bear with me.
Yeah.
So you also have changes in position of the dura. You have changes in position of the nerve root. The dura and the spinal cord are moving anteriorly. The nerve roots are moving anteriorly. If they slide upwards, they're going to be moving up into the pedicle. If they slide downwards, they're moving down into the inferior pedicle. You have obviously length and tension relationships through all of the muscles. The point is that you need to see all of this, right? And that's just fucking gross anatomy, mm-hmm. right? And then there are also underlying physiological mechanisms. So when you elongate a nerve, for example, so let's say you start with proximal sliding, which means you're kind of early in the toe region, you haven't drawn tension to the system yet, meaning you're kind of lower on the stress strain curve. So you're sliding proximally, but you haven't tension yet. Then you draw it back down and you start to draw tension to the system. Well, the tension in a nerve changes physiology in the nerve, does it not? Changes physiology in muscle too. If you stretch a muscle and you put it on length, it changes blood flow, mm-hmm. right? It also changes sensation, right? So, you're activating muscle spindles and Golgi tendon organs. There's a perception that occurs in this whole process where you feel length and changes in length through the entire system, including nerves, ligaments, muscles, tendons, etc. So we need to be able to kind of go all the way from the superficial levels, layer in all the way down to the physiological mechanisms associated with that movement. And then we need to make sense of it. So how would you make sense of it? You'd break it down. So if a person has pain with that movement, you would layer that into individual components sensory motor control, trunk stability, IAP. How is that regulated? How does that influence the patient's pain presentation? You would evaluate very specifically the nervous system, how proximal sliding, distal sliding, and tension influence the patient's pain presentation. You would segmentally evaluate how length and tension through the paraspinal muscles, through the posterior ligamentous apparatus, through the disc, through the hamstring, you know what I mean? All of it.
Mm-hmm.
You just break it out, i.e. SFMA, right? So once we observe everything, then we're funneling into what is the most probable mechanism that underpins this patient's presentation. And that's the fundamental question. What is the most fundamental mechanism that underpins this patient's presentation?
And again, that's a component because that's meat suit component, right? And then we have the mind behind the physiologic brain. So but
that's part of it. That's
right.
part of it. That's part of it, right? So that might be, when I say a fundamental mechanism and talk about the most primary mechanism, and then you might have a secondary, a tertiary, you know what I mean? You might have other drivers.
I don't even think secondary or tertiary because they're coexistent. I mean, it's almost like, quantum mechanics is play, like they're all existing at the same time, and we do have to prioritize. So maybe you do have to kind of give a numerical order to them because of treatment. You can't treat all at once with all interventions, but that's no different than you have to also create an A/B experiment to have a clinical audit process where you're like, am I actually doing anything? And that's where
I guess that's what I mean by primary and secondary is the point of emphasis that needs to be placed on this driver over here, which you think is the most fundamental mechanism now. Now, here's the next layer, right? Is every intervention is an evaluation.
Yeah.
Right. So if you've created a clinical hypothesis based off a patient's presentation, the next layer in your evaluation is to do an intervention that is as specific as possible to the biological mechanisms that underpin that specific driver of the patient's presentation. And if you are on par, you will either make it better or worse. Hopefully better.
Yeah. And again,
but you'll change it.
And when we say it, pain and audits, I'm assuming, again, not to put words in your mouth. Yeah. So I have to ask this question. So there are for sure people listening, but then also just in our profession in general, which we have one of the most contentious, maybe professions that exist. What do you say to those people that say, well, this doesn't matter, right? Why are we going so in the weeds with the details of this stuff when we see this like generalized approach that's become popularized of like people are, the resiliency is low. They need to be load managed first. Yeah, we have to protect them. So we have to be aware of like injury mechanisms. But outside of this, why is this guy, Michael Maxwell, telling me I have to understand these, anatomical things on top of the physiology, on top of the organismal, systems of systems?
Because it's simple. Because if you don't understand the mechanisms that underpin a patient's presentation, you lack specificity of intervention, which means you lack specificity of outcome. It's as simple as that. And moreover, you can injure them. You can harm them. I had a patient that I've been seeing over the last, I guess it's been about 9 months now. She was pain free. She just has diabetes and type 1 diabetes, and wanted to make sure that she was optimizing her health. Hasn't done a lot of exercise in her life, and wanted to get proactive in being healthier. She made a very wise choice. Instead of going see a personal trainer, she said, you know what, I'm going to go see a physiotherapist to design my exercise program, because I assume that their knowledge level is higher and they're going to be better at designing a program for me. Very wise decision. Probably not right, but very wise. So she sees this physiotherapist. The physiotherapist, within a person who has incredibly limited mobility and very poor movement, has her within, a couple months doing like loaded squats, cleans, deadlifts, like a variety of movements that she had no business doing. So she ends up hurting her back, sees this guy for another like few weeks, but loses trust. So she goes back to her doctor, talks to her doctor about it. His doctor gives her a referral to see another physiotherapist. That other physiotherapist does a better job in giving her regressions, so not doing like loaded deadlifts and squats, but still totally misses the boat in the specificity of the intervention required to get her better. She had minus 20 degrees of hip extension. I am not joking you. Like I had to like push hard on her thigh in a Thomas test to get her to 10 degrees. She had 0 degrees of dorsiflexion. 0. She had no dorsiflexion. And she was doing goblet squats.
Yeah.
So listen, it literally took 2 weeks of just doing basic stretching of the tight stuff to 90% knock out her pain. And then
Which
over
that
the
doesn't even
following,
seem that complex, right? That seems
it is
like,
the
how'd you
most,
miss it? Right.
oh my God. Like an incredibly average personal trainer would have recognized this in like 5 seconds. Like unbelievable. But the reason why these other 2 physiotherapists did this is because they believe that the general is what matters.
Mm.
That the specificity doesn't matter, and therefore we're just going to exercise. We're just going to do some back bridges. We're going to get stronger. We're going to do some squats. We're just going to generally exercise because the specificity doesn't matter. Bullshit, it doesn't matter.
Yeah.
Like if you're, it doesn't make any sense, man. Like load matters. Load matters, and if a patient's pain is provoked by a loaded mechanism, i.e., she reports that when she brushes her teeth, washes the dishes, cooks or vacuums, she has pain, but she doesn't have pain otherwise. It's only during those activities.
Mm-hmm.
So why? You have to ask yourself why.
Yeah.
So her supine 3 months position literally couldn't do it. Call it minus 5 seconds that she can hold this position because she literally cannot even hold her legs up.
Yeah. She's doing a squat.
Yeah. She literally cannot hold her legs up. So if you cannot gain basic competency in human movement, why are we training squats? And if you don't see those things, what are we doing?
Yeah.
Like, what are we doing? It doesn't make any sense. So here's the thing. If you don't see it, how can you make a comment or a statement that is not relevant? What I disagree with is that people are making the decision to not see things.
Right. Yeah.
They're saying because pronation is normal and the foot pronates and there's different degrees of pronation and everyone is blah, 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 movement variability, blah, 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 blah. I'm just not even going to fucking look at it.
Yeah. Ignorance is not knowing. Stupidity is not acting on the information you have.
Yeah. So like,
yeah.
I was giving a colleague of mine a hard time the other week, not because I didn't think he was seeing these things, but because he wasn't notating it. I'm just like, hey man, I've noticed like a couple patients that we've, co-treated. When I look back at your chart notes, like I'm seeing a lot of things in their movement that's I think highly relevant or possibly relevant. And I'm not seeing you're notating those findings. Are you not seeing that or are you just not notating it? And then we would talk through the case and be like, oh no, I was seeing that. I'm just like, well, if you see it, you should notate it. Because you can't draw a correlative statement if you don't make the observation.
Mm-hmm.
And in clinical practice, like we don't have any possibility to draw, as you mentioned earlier, a firm causal conclusion. We just can't do it because there's too many overlapping mechanisms that could potentially be at play, right? But we can make a series of correlative statements that if we funnel that down through the mechanisms of the individual patient, we can draw down to the most likely correlation that underpins the mechanisms of that patient's presentation.
Yeah. We're much more like a lawyer than we are a scientist. We have to have a scientific frame of mind, but like in terms of coming to a diagnosis, prognosis, and then an intervention or trial of care, yeah, it's more of, hey, I'm going to present the case first to yourself. So this is what I tell interns all the time. Your lack of confidence is largely coming from your lack of your ability to walk down the narrative that actually makes sense, right? You jump to a conclusion, you miss some piece of information, and now in your own subconscious mind, maybe not even in your frontal cortex, you're like, this doesn't even make sense to me. So it's not, you can't, I don't want to say sell it to the patient, but you can't deliver that narrative to them to get the rapport and the reassurance that they need to stick with you for that trial of care. But again, it plays back to, and again, we could just keep parroting and echoing this, that, the core sciences, prop up everything else you do in practice. But one thing I wanted to touch on in terms of the core sciences that you had mentioned was when talking about mechanisms of, soft tissue mechanisms and the understanding of exercise science. You're like, well, we understand these pretty well. Why do you think it's such a contentious debate within our professions of these mechanisms still, even though I would agree with you that we do largely understand that these things occur in terms of what Stecco's put out and, how, the cardiovascular system is being approached and tendinopathies, but everything, and I'm not saying it's not up for debate. Obviously it is, because nothing's law. There's very few physical laws. But why do you think that you have an approach where you're like, well, we kind of understand these and we can weaponize them versus like some people are like, we don't understand them. So that's why they do take that general approach.
Yeah, I think it's because they're stuck up on the ability to make causal conclusions. So you need a large randomized double-blind controlled trial, blah 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 blah, all of that stuff in order to draw a conclusion on causality. I think that not because we don't understand. Like, listen, we have enough science on the basic biological mechanisms of manual therapy to have a pretty reasonable interpretation of how it might work. But that's different than saying how it is working in this individual patient.
Yeah.
Right. And listen, some patients I'm adjusting not because I believe that they have some specific segmental dysfunction, but because I'm trying to access some kind of an analgesic mechanism.
Mm-hmm.
Right. In other patients, I'm adjusting them because I'm trying to tap into movement at a motion segment that isn't otherwise happening. And in some patients, I'm not doing either because I don't think that the mechanism is relevant to their clinical presentation. You know what I mean? I think the reason why people are so like laissez-faire with all it just doesn't matter is because they're stuck up on the scientist's version of this, and the scientist version of trying to bring us towards some law of causality is probably not going to bring us to any firm conclusions on an individual patient in about 1,000 years. You know what I mean? Like, because every patient is so distinctly unique in their physiology and their biomechanics and their anatomy and their, emotions. It's way too complex.
Yeah, you can't test it. Yeah.
Yeah. So all we have is a bunch of data points that we collect from an individual patient in which we can create a narrative that draws us towards the most likely causal mechanisms. But that doesn't mean we're concluding that, I'm directly intervening this therapy onto this causal mechanism, and this is exactly why it's working. No, it's just like one clusterfuck of physiology that is influenced by a variety of different things, right? So it's like you made a statement earlier, like people say, well, general exercise is all that's required. But they're making a statement that general exercise has general mechanisms, and it does not. Mm-hmm. General exercise has very specific biological mechanisms, right?
Yeah, otherwise I get huge biceps from going on a walk. Yeah.
Exactly. Yeah. So there's no such thing as general exercise in the realm of physiology. There's no such thing. We call it general because it's things that people generally do, I guess. Like, I guess walking is a general exercise. Yeah. I guess, hiking is general exercise. But all of these things have very specific physiological mechanisms. And so the question in an individual patient is, are the specific mechanisms that I'm looking towards going to be most succinctly gained by a general exercise approach? Or do I need a specific intervention or a specific exercise to get that specific mechanism?
And if we wanted to take, I'm being honest, if we wanted to take off our, pleasantries, and I know that you're Canadian, that has nothing to do with it, but like people are lazy. Like clinicians sometimes are just lazy, right? And the bandwidth that you're putting into each patient visit, each minute, it sounds like is very high. So right, the throttle's down.
It's really tiring.
Right. And that's what, but I think that some people are like, well, I'm going to make some money and I'm going to see 50, 60 people a day, which my retort to that is like, how could you, it's the impossibility of both time and bandwidth there is like, I don't get it. And maybe that's just my lack or, my limitations. but at the, you know, if we kind of wrap this up, because we keep coming back to this, like you have to kind of have a filter to apply this stuff, which gets into the evidence, you know, that we're basing things on. You still have to interpret that as a clinician, right? You cannot take, you know, the conclusion or, you know, the methods and say, well, that's what we apply, because that's not how it works, right? It may work in one out of 100 that they're the textbook. Man, I went through, you know, Keith Barr's tendinopathy protocol verbatim, and it was just like, boop, you know, perfect. Like that is a rarity, even if it does exist. So I want to put kind of a bow on that, because I know we're just keep, you know, beating it down, and I couldn't agree with you more on this stuff too. But I want to kind of open it up to more general, because again, like I mentioned, you own Somatic Senses, or co-own it, I believe, still with Ben. And you've been in the continuing education realm forever, which it's even funny that we call it continuing education, that like that's part of our job. So to think that like you're doing more than other people is, I wouldn't say laughable, but it's like, hopefully we'd all be motivated to learn as much as we can, to help people as much as we can. And it's not hopefully just a selfish endeavor. But if we're going to be educating ourselves and educating clinicians, what outside of what we learn in school, core sciences, generalized methods, adjusting, soft tissue, things like that, are there core competencies of a clinician that you think need to be present outside of the clinical skills to actually be good at this job? And maybe, you know, if you want to get to that world class, like they have to be present. And I mean, that could be anything from soft skills to, I mean, you know, creativity. Like, I mean, there's all sorts of things that play into the job that you and I do.
Yeah, I mean, so we're specifically excluding, you know, or taking for granted that we already have a basic education and physiology, et cetera, right? So
Yeah, because the tough thing with this question again is we learn certain things in school, and we know that we don't learn all of the things in school that you and I use in practice every day, right? So let's take that at face value, that there's all of these other, I would say, concepts. I hate to even say methods and techniques. Like there's concepts that have been applied using, you know, science, you know, i.e. neurodynamics, DNS. It's people understanding the core sciences, looking at it through a different lens and applying it over and over, and, you know, maybe eventually testing it or, you know, methodizing it. But is there anything else that you're like, God, if you can't creatively think, if you can't have an imagination, if you can't storehouse information and, you know, critically think within a visit, like it's just not going to happen. Like it's going to be impossible.
yeah, oh man, this is such a layered question. I think being keenly present in every single moment that you have with a patient, and being astutely aware of all of it, is probably the most imperative first principle. With the second, which comes very close next to it, is asking the question why. So, you know, I remember observing he was a neuropsychologist a few years ago, and seeing him work with patients, and him commenting afterwards, like, hey, did you see this? Like, he was seeing like, you know, pupillary dilation and constriction, and he was seeing like, you know, soft brows and raised, you know, nostrils. You know what I mean? He was seeing stuff to a level of, you know, acuity that I just wasn't seeing.
Mm-hmm.
And so it just requires an incredible presence, and awareness and observation of the patient to be able to see the things that you need to see to dial in to, you know, the most probable mechanisms that need to be addressed on that patient. And I think, you know, listen, like DNS is, you know, learning from Pavel and the Prague school. It's a little bit like a shortcut in the sense that it probably would have taken me, you know, 40 years to figure the shit out that I learned from them, in a couple of years, right? And now that I have that lens, now my future learning is catapulting off of that new foundation. So that's really where I think continuing education comes in. It is that, okay, if you were present in every single moment for every single patient, and you had enough time with them to make appropriate observations and ask the question why, you might get to where Pavel was, you know, 40 years from now. But, you know, when you go to continuing education events and you see how other people are thinking, and you hear how they're processing, and you see what they're seeing, it gives you like another layer up to see new things that you hadn't seen before. But I think it all comes down to just like this inherent curiosity of trying to understand what is going on with this patient and why are they experiencing pain. And that means that you have to kind of go down rabbit holes. And something that I don't think we do enough of, and this maybe is that might be a totally unfair statement actually, because I don't know that people are not doing this. My impression is that people are not doing this. But I don't think people are taking their chart notes at the end of the day or at the end of their week and going through those 2 or 3 patients where they're not 100% sure and reading through it and dissecting it and reasoning it. And then asking that patient, be like, hey, you know what? I don't think I got this quite figured out. Can you book a re-exam next time so I have more time with you? Because I want to take another deep dive on this because I'm not 100% sure I've defined this with the clarity that I need to move forward. And I think that needs to happen a little bit more. And that's why I challenge my colleague to make those notations. Like, okay, if you're seeing it, write it down, because when you go back and look at that patient's chart, you can start to make sense based off of all of the data that you have and the interventions that you performed and the progress of that patient of what were the most likely mechanisms at play. And then over a career, you start to recognize those patterns a little bit quicker. So again, present moment and curiosity. I think those are the first principles that I would say are most imperative. Sometimes the answers are going to come at, I don't know shit about this. I got to go on PubMed and do a deep dive into some research and learn more because, man, like I still feel like a total fucking infant. Like when I take a moment and pause and I read through the literature, there is so much to learn. It's ridiculous. I had a patient come in the other week, has this weird, neurological condition that I had never even heard of before. Turns out it's a biomechanical mechanism that influences physiology, specifically of the spinal cord, whereby the dura in the spinal cord essentially shifts excessively anteriorly, often associated with a kyphosis of the cervical spine, like a loss of lordosis. And it creates an ischemic and inflammatory mechanism in the spinal cord. And it almost presents almost like ALS, but it's very focal. It tends to have like a short clinical course that reaches termination, but you don't recover from because essentially the nerves die. So it's like, shit, I've never heard of that before. But once I took a deep dive and I was like, oh man, there's another differential diagnosis for a slump test.
Yep. Yeah. Well, the crazy thing is it's literally like you're teaching my course right now. Like and the only reason I have a course is because you say the same things over and over with new grads or interns, or when people ask you questions and you're like, I teach a whole section on observation, and people think it's kind of silly because I'm not just talking clinical observation. You build observation skills by being more aware in your general life, right? So like we were at a course in Texas, and the guy that owns the clinic drives into this clinic every day. There's trees outside his clinic. And this is just kind of a proven thing that for every plant that you actually know, like the name of, and then the scientific name, right? You have a further understanding of the ecosystem. And then if you understand what animals would live in that tree and all this, and we kind of play this game, like everybody go outside. Everybody that's at this seminar was from Texas, not me. And I go, can anybody name any tree by just name, plain name, not one person? Which again, if you're like, well, I'm not an arborist, my parents didn't spend time, whatever, but you drive by this stuff all the day, you can't even name it, which then paints your reality. So all I was trying to point or, draw the picture of was, hey, your observation and your awareness is going to be determined by like your conscious level activity. That's no different than you being in the room. And you said like being aware of how they respond to a word or a statement that you say, how your posture affects their posture. Do you need to use your position, posture, stance to then facilitate something in them? And like the more aware you are of these things, just the easier job gets, which is already hard, right? To have this kind of diagnostic, mechanistic, interventional approach, but then you're like, okay, I have to make my job easier by understanding all of it. And then like I said, curiosity is at the heart of it. And you're just always asking why, or how could I get better? Why did that actually happen? Right? you have some whiz bang effect and you're like, well, I thought it was this, but man, that like got it better a lot faster, changed much quicker than I thought it could, or didn't change at all. So if we have those core competencies, if we, reviewed of kind of curiosity, observation, or awareness, if we want to say that, in the room, if you're building a team of doctors around you, right? And let's keep it within our profession. If you're like, I wanted to work around the top 5 physicians, clinicians, whatever you want to call it, in our realm, conservative musculoskeletal care, as of right now, we'll just call it the Avengers of musculoskeletal care. Who would it be? And then why would you pick each one?
Oh man, so many options.
And again, there's people you want to hang out with, and then there's people you want to learn from. And
it's not fun to be alive.
No. Yeah, let's go. You can go dead presidents with it. Yeah.
I mean, I think Pavel would be a clear one. And
why him specifically? I can assume, but just give me a quick why him specifically.
Pavel approaches his work with a level of curiosity, and there's just this incredible depth to his knowledge and breadth to his knowledge that he then applies with this very persistent sense of asking why and trying to figure it out that I find just incredibly inspiring. Like he's probably one of the most knowledgeable clinicians in our world, and he just has a tremendous sense of humility in how he evaluates patients because he just continues to ask the question of why. He's just incredibly thorough and comprehensive. He also has, I think he doesn't get a lot of credit for this, probably because of English not being, his primary language, but he has a way in how he interacts with people that almost like invites you in. His emotional intelligence, I think, is incredibly high. So, it's a tough question for me because to be honest, like I would rather put myself in a room of people where I don't think or feel like I've mastered those skills. So I would almost like want to be in a room with like, I don't know, like say Michael Gervais or something like someone like that. So part of being a growing practitioner is understanding who you are as a person, what your strengths and limitations are. And my strengths are definitely in the realm of observing people and collecting data and reasoning through the data to come to reasonable hypotheses on a patient's presentation. I think that's my strength. My weakness is very clearly like social interaction intelligence. Like I'm fairly like my affect is fairly serious in my demeanor. A lot of my patients, feel like I'm really serious, and it's not because I'm certainly not mad or angry. I'm just like, that's how I concentrate. I'm very quiet in the clinical room. Like I don't talk a lot. Like it's when I teach courses, I'll make the comment of like, I actually don't like communicating that much. I would much rather be silent in the treatment room and not talk at all, because I want to be acutely aware of the patient and me and our interaction in a nonverbal respect. So for me, communication with other people is my limitation. So why would I want to stick myself in a room with someone like Michael Gervais or someone in that realm is because I feel like they're just wizards at communicating with people in an emotional and social context. And that's a limitation that I have that I would like to continue to get better at. And I continue to work on that weakness as I go through my career, because I think my strengths are way the hell up here. My weaknesses are down here. And I know that I'm never going to bring my weaknesses up to my strengths, but I want everything to shift up throughout my career. So I'd say someone along the realms of like Michael Gervais, Pavel Kolaj. I would love to be, in the room with someone in the realm. Like if I could, like Feldenkrais, for example. Like I'd probably say Feldenkrais would be one. I might, I never met Ida Rolf, but I might say Ida Rolf. And a close second might be my colleague Mark Finch, who has taught for me in the past, but I just feel he's like incredibly talented with his hands, and his observational abilities are incredibly refined. Um, and I think a final one would probably be someone in the medical world. So, and I don't even really have like top names off the top of my head, but it would be, you know, someone from the sports medicine or surgical realm that has mastered the ability to evaluate a patient, and from their unique perspective, which I don't think we always share. It kind of goes back to like my clinician back when I was at UWS DeLapp used to always kind of hammer on us about having a comprehensive list of differential diagnoses, and we would never really like reach his standards because he would always ask us, what's another one? Like, what's another one? And I feel like chiropractors, because we have this like fairly contained environment where we don't see all the stuff that like goes into a hospital, for example, or to a neurologist or a neurosurgeon, et cetera. I feel like sometimes our differential diagnostic list is too short. And I feel like that's a limitation created by our environment. So the other person I would want in the room is someone like a neurologist, a neurosurgeon, or a sports medicine doctor who is in that world and sees things from a slightly different lens.
Well, on that note, so I bring up this book called The Six Thinking Hats by Edward de Bono, who basically he's a physician, but then kind of get into the finance world based on this book. So the six thinking hats are these 6 different colored hats that basically walk you through the process of thinking. Black hats is like the things that could go wrong, right? Red hat is intuition. The green hat is divergent thinking, which is differential diagnosis, right? It's the explosion of all the possibilities. The convergent thinking is the pruning of the possibilities down to some sort of something that makes sense, but also the black hat, like, I got to be aware of this. So you have the yellow hat that's kind of that convergent process. And then we just kind of, and then the white hat, is your like objective data. So it's the data that you put into this. And I always bring that up because you'll fall to the level of your systems, right? So if you lack clinical awareness, you could create, that's what the whole SFMA is. Hey, if you're not going to look global, we're going to force you to, right? And then we're going to hone it back in and break things down based on what the findings were globally. So I love that you're like, yeah, I need somebody that would look at it in a different light, because I agree that we look obviously musculoskeletal, but then we need to look at the other systems that can affect the musculoskeletal. But then also, I've never even heard of this thing. Now it's in my purview because I'm aware of it. And now I'm always aware of it because of that. But you had to be aware of the possibility of the thing in the first place, right? Not shut it down to, doesn't make sense. I love that.
Hey, what was the name of that book again?
So The Six Thinking Hats, Edward de Bono. And then the physician that I would pick from the medical world, if I was in, asked the same question, if you're like, I want somebody that's world class of basically thinking outside the box of the possibilities from just medical, right? What's going on with this person that's not allowing them to be healthy or out of pain or whatever? Arturo Cosadebal is the head of molecular biology for Johns Hopkins, is kind of the head of their, I guess, at the head of using AI as the diagnostic agent once you put in all the data that you still have to be aware of, right? That's the key. The physician still has to pump the data in or prompt it to then say, well, God, I can't look at 15 million studies all at once and, all the case studies and reports. So his take on medical training, which gets at the heart of what we kind of started this conversation, is we need less didactic training and we need more clinical reasoning right from the get-go, is literally at the heart of everything that he teaches. He goes, the didactic is necessary, but he goes, if we have this massive AI computer learning system that's going to be able to store all information, then your job is you have to basically learn how to look at the patient, observe, deduce, and then prompt appropriately. And that might change over time, but that's still we've been in that role for the past, millennia, and we're still in that role right now currently. All right, let's keep rolling through these. So what is something, again, in the medical world, we'll just leave it to that, so it's not just outside of that. What's something in the recent future or in the recent past, sorry, that you have changed your mind on? Something that you held true for a long time that you're like, who, based on information, based on clinical experience, could be either or. You're like, yeah, I really about faced on this thing. Does anything come to mind?
Yeah, I mean, this is not a recent discovery, but I would say that diving into Shacklock's work, Beau's work, and yeah, I mean, when I went through chiropractic school, I wasn't so into the philosophy of chiropractic, but and I'm still not. But the original tenet that um, the terminology probably needs to be changed, but the original idea that clinical symptoms of a patient are created by compression of a nerve or a pinched nerve, as they would describe back in the day. Man, I'm seriously still mulling that over a lot now because it's like if you have symptoms in a muscle outside of a tear, like for example, like my right TFL is feels tight right now. I can stretch it, it doesn't get better. And a lot of patients are presenting with the experience of tightness, and it's not because the muscle is tight.
Mm-hmm.
And in the end of the day, of course, we know that there can be a protective pattern, but I think a lot of patients are presenting with like low grade irritation or activation of the nociceptor within the nerve neuron that's creating a clinical pain presentation of tightness that's driven from the nerve out. And even if you think about like when you stretch a muscle, what are you actually stretching?
Mm-hmm.
Or how do
First,
I say
yeah.
that? How do I say this differently? When you stretch a muscle, what is the reason why you feel a stretching sensation? The only reason why you feel a stretching sensation is because you're pulling on a nerve.
Mm-hmm.
And you're pulling on the nerve, obviously through to its terminal, right? I.e. the receptor. But in the end of the day, you're still tugging on a nerve. So it's almost like, everything actually interacts through the nervous system. And even something as simple as a tight muscle ultimately comes down to why is it tight, and is it because the nerve is
Mm-hmm.
irritated or compressed? And I don't think it's as simple as it's always the spine. Of course, you have many different peripheral entrapment neuropathies, but I think a lot of the experiential learning that we go through in clinical practice is trying to funnel down like what is the balance of factors that leads into this patient presentation. And what I've kind of been shifting towards is that often it's just an irritated nerve.
Well, and what I'm constantly curious about is when you keep. I like the word irritate because we use sensitize and all these things that maybe are misnomers, but it's like, why are these things getting irritated? Because it's not always compression, right? It's not always mechanical irritation. It's not maybe, we've had all these, the Cinderella hypothesis, all these things. Like, that's kind of the thing. And, again, you're being curious, right? Is it systemic irritants? Is it, systemic inflammation, environmental issue, like whatever it is that like, is this why we're seeing the musculoskeletal burden? Is that solely tied to sedentaryism? All these things come to mind of like, well, what is creating this maybe peripheral irritation that then can almost, in sequence cause, central changes. Obviously, it doesn't take much to have some sort of cortical change. But yeah, that's something I'm curious about now is like, okay, why is this occurring? Because it's not always mechanical. I mean, that's, obviously we know that, but we don't know why.
Yeah, well, I mean, if you go, let's say you've got, a superior cluneal neuropathy that's not, derived from a spine related complaint. So let's say you have an, inflammation and an observed thickening of the superior cluneal nerve and the fascia that exists between the erector spinae and the QL as it passes down the flank space and ultimately over top of the ilium. The question is, what caused that thickening of the nerve? what caused the inflammation of the nerve that resulted in that. And what I think what you're pointing to there is that like the global physiology is a potential input into the health of the tissues, the health of the nervous system, the expression of inflammation. And if you didn't layer on those other factors of systemic physiological inflammatory mechanisms, maybe it wouldn't have ever evolved into a clinical condition.
Right.
Maybe the system would have been able to navigate through the present challenge of compression or tension or whatever you want to call it, and just come out of it just totally fine.
Yeah.
Right. It's like, it's not necessarily the load on the system that causes the problem, but the response to the load on the system. It's like the difference between like, what was it? Shear, I think it was, tendinopathy study out of the UK where they looked at patients with history of tendinopathy and patients without a history of tendinopathy, and they both had them go through a loading protocol, and they observed via ultrasound the response within the tendon. I think they did, I think they might have evaluated blood flow as well. But anyways, Cliff Notes version is that those who had tendinopathy and those who did not have tendinopathy both had a thickening of the tendon in response to heavy loading. But the ones who had a history of tendinopathy, that thickening and the swelling essentially of the tendon persisted for like 4, 5, 6 days, whereas the ones who had a healthy tendon, it abated within like 24 hours. So, same load, different physiology. And we know now that there's an epigenetic shift within these tendons in which that tendon is now primed to express inflammation. So same load, different response. And that's not necessarily because the collagen is different or the collagen can withstand a different load. Although it might be, but it could just, it could be both, but it might just be the cellular response to load that's aberrant or abnormal, which then goes back to the rabbit hole of asking why. And maybe part of the why, based off of what we know about, risk factors for, degenerative tendinopathies and arthritis, is that systemic physiology has a massive influence over that. So maybe that's a big part of the priming of the system, or the inadequate response to load, or even a load that induces a cycle of inflammation, the ability to recover from that versus end up in this cycle of persistent inflammatory mechanisms that results in the degenerative cascade.
And that's where you can be a sneaky clinician, because you can know the physical phenotypical presentations of different genetic SNPs. And I know people are like, there's all sorts of things. We know the big ones, right? Fair skin, redhead, collagen, distribution. But like all of these things come about where, again, are you going to pull a genetic panel on every patient that has no, that's, but there's likelihoods, right? And the likelihoods play into, well, I have these diff dyes, right? I'm still going through this pruning process. And now that I have these likelihoods present with the history that this person's telling me, with their previous treatments, with whatever's going on, and you're like, oh yeah, like what I would do with somebody else, I can't do with this person, right? Even though they may have the same pathway anatomical diagnosis, which is what that study is basically saying. I think that's beautiful, because that's again a curiosity thing of, God, if they had the FOX2 gene and they have a double allele of the IL-6 gene, like this is going to be a terrible scenario for somebody that I take through like ballistic loading, when they're feeling good. Like it's just going to be way too soon, right?
Yeah. Is that drive? I can't remember the author of the study that Tom Myers wrote about. Not Tom Myers, Tom Mashad wrote about recently, where those who are essentially hypermobile, versus someone who is not.
So that's Keith Barr's work. Yeah, out of UC Davis. Yeah.
Yeah, so the response to load is dramatically different depending on the inherent, connective tissue makeup of their tendon, essentially. So, those factors that would be another, I think, pivotal shift. And I actually learned that from Pavel first, actually, was the focus and attention to connective tissue quality. Like just general connective tissue quality, which I think you can get a pretty good feel for just with your hands, the compliance or elasticity of the skin, the fascia that underlies it, the muscles, all of it kind of gives you a phenotype of the patient's connective tissue quality. And then maybe that can give you some information on how you would proceed into a loading protocol. I want to go back for a second because,
Yeah.
you know, you mentioned something about Ben, and how he said, you know, it doesn't really matter because you just end up, my hunch is that what he's saying is in the end of the day, you just end up loading the system in a way that their system tolerates, and you just progress them through some kind of a loading protocol, and the specificity doesn't necessarily matter as much. But the thing is, like, Ben is a fucking outstanding clinician.
Hmm.
You know what I
Yeah.
mean?
And that
Like
was no
his
knock on him.
reasons.
It was just, yeah.
No, I didn't think it was. I didn't think it was. Yeah, because I just know, like, I've seen Ben work, and I've seen Ben think. More importantly, I've seen Ben think and work through thoughts and work through. Well, we've talked through cases together, and he comes at movement and loading in a different way than I do, but we kind of are still pointing towards the same underlying mechanism, just in a different way.
Mhm.
You know, he uses, what I really appreciate about Ben is that he uses a very creative space to come out, and come into loading protocols to change or influence loading parameters within an individual patient based off of their pain provocation mechanisms and their pain relieving mechanisms. And so, you know, he might do that with, you know, a single arm front rack reverse lunge, but he loads a single arm front rack on the left side because he's trying to unload the left. You know what I mean?
Mhm.
So he's coming at it from a way that's incredibly specific, at the same time very general.
Mhm.
And that's like the ability to kind of zoom in, zoom out of like what's general and what's specific, and understanding there's nothing really that, you know, that is general. It's all specific, just with different mechanisms. I think is really important, because Dimitri, when I was chatting with him a couple weeks ago, me and Dimitri, probably about on average, you know, once every couple months, we'll hop on a call and we'll end up chatting for like 1 to 2 hours about this stuff. He kind of, you know, we had an in-depth conversation about phenotyping of patient pain mechanisms and patient presentations. And he kind of said the same thing, as in the end of the day, I'm not sure it really matters, because we end up doing all the same things, which is exercise, manual therapy, observation of social, emotional, and cognitive factors, and addressing those as we need to. And we kind of do that with every patient,
Mhm.
you know, which is true, right? So, you know, we do all of those things with all patients. And in the end of the day, even if we have a very specific mechanism for a patient's pain presentation, is our goal not to make our patients generally healthier? So am I aiming towards getting my patients engaged in exercise or activity that would be consistent with the international guidelines for exercise and activity? Well, yes, I am. And that ultimately funnels back down to being generally healthy, right? So whether I start specific and move general, or go general and focus on the specific if I need to, doesn't really matter.
When all it comes
You
down
know?
to, honestly, if that's how we distill it, if it's, you know, it's two funnels that are connecting in the middle, then it's just effectiveness and efficiency, right? Because you could still get the
That's
same
the
thing
thing.
done in more time or less time, or more frustration or less
Yeah, yeah,
frustration,
yeah.
both for you
Or
and the
the
patient.
most important part is buy-in,
Yeah,
because
100%.
the
Yeah.
patient has to feel better
We got to show
for
back
you
up.
to get to show back up, right?
Yeah.
So sometimes you need to make sure that your specific intervention initially gives them some relief, so that they know that if they continue to move forward with you, they will get to their important outcome markers,
Right. Yep.
which is
Yeah.
just feeling better and doing what they would normally do in life without having pain,
Yeah.
right?
And that even gets
So
to your point of, you know, you mentioned earlier using, you know, an adjustment or mobilization for specific reasons, but then also using a pain alleviating or symptom reducing intervention when you don't think, as a clinician, that is the biggest piece of the clinical puzzle. But you're like, I need this to die down. And I mean, I'll tell most people that, right? I'm sure, I don't know if you're, I mean, I'm like, hey, I'm doing this because I want you to feel better. I don't know how much it's going to change these audits I'm looking at. But like when you know, and then we always kind of have the combo of like, yeah, pain alters movement. And so we want to kind of eliminate that anyways. But like, you know, yeah, you have to get rapport reassurance and get them to show back up. And that's how you
yeah,
create your A/B experiment. So you have the clinical trial to go through. Yeah. So again, you and I agree on everything. I mean, I'm sure in the clinical realm, there's very few things we disagree on. You're just such a bright mind in terms of the details, right? The diagnostic accuracy, the mechanisms behind these things, always asking why. That's why I like to just kind of explore your mind and be like, well, you know, why did you arrive at why these things are so important, right? Why do you approach your, you know, clinical process in this manner? And I think that's where students and docs and, you know, even lay people are like, oh God, there's somebody out there that's doing it like this. I either want to, you know,
I
mirror
mean, it
that,
just
or I
comes
want to
down
push
to really
myself.
just, yeah. I mean, honestly, it comes down to just really caring about your patients and caring about their outcomes. Like it bothers me when I can't help people. It really bothers
Mhm.
me when I don't, even if I have like, if I have one interaction in a day where I'm just like, I didn't nail that one. That was not a therapeutic intervention in the sense that it didn't help that patient on that day in the way
Mhm.
that I thought it could have. That bothers me, and I'll think about that for well, my last one was 2 weeks ago, so I'm still mulling over that interaction 2 weeks later
I have one coming in today.
on
Yeah.
and on how I could have been better, right?
Yeah.
And that you know just and it maybe part of that's ego. I don't like being wrong. Yeah, I don't like being ineffective. I like being good at what I do. Um, and part of that's driven by just fundamentally caring about the people that you're working with. And if you care, it's them that's going to drive your motivation to look
Mhm.
deeper and move forward into that process of clinical reasoning, right? That's like, sometimes I'll tell my patients, like, I often work like afternoons and evenings because mornings for me is a very creative space. That's where my brain is like most effective and most active. So I like to have mornings alone for my creative time and writing and reading and all those things because I'm way more effective in that time of the day for those things. Because I know that the second that I get a patient in front of me, they're going to drive that.
Yeah.
You know what I mean? Because the motivation is so high to do a good job for that patient that it just brights your lights your mind right up. You know what I mean?
And
So
I'm assuming
um,
you and I, being in the field and kind of practicing similarly, when I get done with a day too, it's like I have 6 more things I have to look up, think about. So it's like, that's where you have to, and this is why, I call this the distillation process, which you kind of talked about earlier with your clinical notes, which I preach too. You already have to do your notes, right? Legally, you're bound to do notes. Now, to what level you're going to do your notes, well, yeah, you have to pass an audit and all that stuff if you're insurance bound. But if you're already doing them, why wouldn't you take the time and effort to have something that you can review? But reviewing your notes is also different than a creative ruminative process where you're actually now trying to distill ideas into something that's not necessarily conceptually different, but that you're like, oh, I could have approached this case like this. I've never thought about it like that. I've seen this pattern occur. That's clinical leaps and bounds. That's not just sharpening your sword. That's literally getting a different sword, right? And I wish more clinicians. I know we're busy. I know we have families. I get it. Like 30 minutes a day, right? An hour a week, whatever it is, to do what you're
yeah, well, we
doing.
don't. You have to schedule it in though, right? And I think
Yeah.
that's you just pointed you. I think I mean, I've always been a little bit obsessed with this stuff, and I acknowledge that I'm different, and not everyone is going to do 30 or 40 continuing education courses a year. Like that's not normal. Um, so I do have to accept the reality that that's not a typical, you know, thing for people to obsess about these things to the degree that I would. But I think in the end of the day, like even practitioners who have full families and busy home life and full clinical practices, they just need to schedule the time. And I know that a lot of clinicians that I've met over the years, like they just schedule half an hour in the morning where they'll read an article or they'll read their chart notes, and they do that every day. One of the senior chiropractors, he's retired now. He practiced for 38 years full time, 41 years before he hung up the hat fully and stopped doing like preceptorships for us. His dad was a chiropractor. His brother was a chiropractor. So like, through and through, just a chiropractor at heart. And he was passionate to the day he stopped practicing, and still to this day actually comes in and talks with us and still speaks with passion about the work that he did and continues to do in volunteer work. But my point is that he would come in early to work every single day. He would go through all of the patients that he had in that day, and he would have a system of labeling each patient in what he wanted to work with them
Mhm.
within each visit based off of what he had seen the last time he saw them, etc. And so just that process of like reflective reasoning is, I think, super important to continue the evolution of your practice. Um, yeah, I mean, I get it, man. Like, I don't have kids, so I'm not, when I go home, outside of spending time with my dogs and my wife, I've got time to read scientific journals and write articles and things like that. And I know people don't always have that time, and I have some empathy and understanding for that. So it just means that in those scenarios, we just need to book the time into our day. It's not, you can't just go treat patients 9 hours a day and then clock out and then go back and treat patients for 9 hours a day and then clock out. You need to clock in at a different time to continue to learn and evolve as a clinical practitioner, because there truly is like no end to learning. Like I don't feel like I'm any nearer to the conclusion of my learning process than I did 20 years ago.
I call it competent confusion. You realize, I mean, this is in every field in the world overall, right? Yeah, the more you know, the more you realize how little you know in the whole body of like your field in particular, and then in general. And that can be a little defeating, but what I kind of came to was all the people that I looked up to or still currently look up to are very competent, extremely competent, but they're as confused as all of us because they're like, Jesus, we don't understand 99% of the stuff that we're looking at to the level that we can be absolute, right? And absolute doesn't exist in our world, right? So you have to be okay with gray, but then that's that. I'm highly competent. I'm still confused. I have to fuel the confusion with curiosity to keep learning. I think that's what you're, world class at. I mean, we need people like you. I mean, I'm not saying people that are, no kids and have all the time in the world, but we need somebody that's going to distill this very highly intentional clinical practice into education for other people, because some people might not have the time that you do. Some people may not have the motivation that you do. And, some people might just be a little bit lazy. So I hate to say it, if there's a Michael Maxwell out there that they can learn from or utilize to read articles, go to classes, that's maybe, what you're here for, is like, you can be that conduit of like, hey man, I kind of got your backs. Yeah, the onus is still on you to take this information, make it your own, but like, I'm going to try to help distill this thing. Do you ever feel a burden of that, or is that just a fun motivation, or is that even in your purview of like, yeah, that's why I'm doing this stuff?
Yeah, man. It obviously, for me, it's driven out of just like a pursuit of knowledge, and I'm just a curious person, and I get bored really, really, really easily. Like if I don't either teach a course or attend a course like every, I would say like 8 weeks is like my ideal limit. I just start to feel stagnant. I feel like there's a plateau, and that stagnance and plateau kind of is almost like there's nothing that's pushing me further. You know what I mean? Like I'm in my own head, I'm in my clinical practice, but it's when I get out and talk to my colleagues, whether I'm teaching and receiving questions and having to think about the questions that people are asking me, which promotes learning, fosters new questions in my mind, which then I go research, whether I'm learning and going into a clinical environment where someone else is talking through their clinical process. To me, that helps kind of like keeps me driving forward. So I don't think we're immune to that plateau. I don't think anyone is. And I think we all just need to get out there and talk to other people to learn more, to kind of in the pursuit of curiosity. Because like, I know that we're on the same page with a lot of things, but you're still a different brain and you think of things a little bit differently. And I know that if I talk to you enough, I would learn a lot from you, and probably vice versa. And you know what? The reality is, if I sit down and talk with my colleague in the office who's got a full-time family and isn't a total continuing education nerd like me, but still a passionate chiropractor who cares about her patients, I know I can also learn a lot from her, because she's a social wizard. You know what I mean? Like she, the way that she interacts with people, the way that she communicates with people, how she cares for people, or more specifically, how people feel cared for in her presence, is something that I can learn from. So we all are fitting roles within this community. I'm just fitting a very specific role based off of my specific strengths and passions, and other people are filling very different roles. And not like, I'm not the best chiropractor for every patient. Flat out, there's people who are going to come into my office and be like, well, you'd be much better served with Dr. So and so down the road, because from a personality perspective, and for what you're seeking and what you're looking for, I think you would be better served seeing that person, because their strengths fit with what you're looking for and what I think you need. And our personality types aren't necessarily going to jive based off of my strong, firm, quiet demeanor. And what you need is something that's a little bit more warm and fuzzy, and that's just not me. You know what I mean? So
that's being aware just in a different way. It's self-awareness. So you're turning the awareness back on yourself instead of, the clinic, the treatment room and the patient. So,
yeah,
and that can be harder to do, and then maybe even harder to act on. You might know I'm not saying you, but like if somebody's like, man, I kind of am a little condescending sometimes in the treatment room. And if you know that, you still got to act on it. you got to have some sort of like intervention with yourself of like, okay, what am I going to do about this now?
yeah. And you know what? The thing is, like, no one's going to be perfect all the time. And it just comes down to being like, you know what, I apologize. You know what I mean?
Yeah.
That wasn't the best interaction with you the other day, and I apologize for that. And then having a conversation with the patient to make sure that they're good with moving forward and that they feel you're still the right person for them. And if they don't feel like that's the case, then you need to move that patient along to someone who you feel would be. So yeah, I mean, I don't think like, there was a movement against gurus in the last 10 years. And I think it's gone too far because I think there legitimately are gurus who are ridiculously good at what we do. And Pavel is one of them. But I also know for a fact, not because I've been in Pavel's practice, but I know for a fact Pavel doesn't get everyone better.
Yeah. And
You
it's
know
a
what I mean?
possibility. Yeah.
Like there's no guru who is the best practitioner for every single patient. And sometimes they just need an average practitioner who's going to hold their hand through a troubled time and give them some basic skills and tools to move forward with some basic treatments interventions that they're looking for to get them through this. You know what I mean? And sometimes that's just what it is. Sometimes it's just you have a patient who's going through an incredibly difficult time. They're holding tension in their body. That tension is manifesting as pain. And until they move out of that period, they're probably not going to find resolution. And maybe you just need to hold their hand through there and support them through that process. You do need to obviously seek some degree of understanding within the patient that, listen, there's social factors at play here. That's okay. I know you're going through something and I'm going to help you through it. And that's not treating a nociceptive mechanism. That's treating the social and emotional mechanism to make sure that patient feels cared for. And we mentioned or alluded to it a little bit ago, but sometimes the most analgesic thing that you can do for a patient is the thing that they think would help them most.
Yeah. Well, yeah. We always say if they told you, if somebody's like, I went to an ART practitioner for something in the past and I had wonderful experience, 100% resolution or whatever, and you don't take that into account, and I'm not saying you always just do some mimicked action, but you don't take that into account and think that like, ooh, that could be a very strong pain alleviating or rapport building mechanism that I utilize in some form or fashion. I think you're being an idiot because you're just bypassing, like they just literally told you what I like. And that is such a big part of that clinical, therapeutic partnership. So yeah, I couldn't agree more.
What's really hard though for me is that when you know that is not going to help them.
Yeah. Yeah.
Like I find that super challenging. Like I've had patients who have come to me and they clearly have like a micro instability of their lumbar spine that's being perpetuated by activity XYZ. They've seen a chiropractor, they get temporary relief. It lasts 2 to 3 days, but it keeps on coming back. They've been going through the cycle for 2 fucking years, but all they want is an adjustment. And I'm like, that's hard for me to just be like, have the humility to step out, like, okay, I guess we're doing this. You know what I mean? I guess we're going to do an adjustment today, even though it's like, in a way, even potentially contraindicated for your clinical presentation. But if I don't do that on that patient, maybe they're not going to come back. And so if I want them to come back to get to what I think is really going to help them, maybe I just do what they want me to, as long as I know that it's not going to harm them. You know what I mean? And as long as it's safe. So
that's tough, especially, I know when I was new in practice, how I tackled those scenarios is also wildly different than how I tackle them now. Because I'm still going to broach the subject, right? I'm not going to just walk away from it, adjust them and be like, but at some point to get the buy-in in what we actually need to do, right? The best, clinical intervention for them, you have to kind of at some point, without saying it, like, hey, that's not the right thing, right? That's not the best thing. But we actually, in a team meeting just last Thursday, talked about internal and external rapport. So like if somebody's referred in here from somebody, right, like a trainer, and you think that what they're doing with that trainer is hurting them, but maybe that trainer is their best friend. You have no clue, right? You have no clue. It's just on their paper. And then you go about your business, and maybe even in a nice way, saying what they're doing is wrong or hurting them. You are literally dissolving trust as you're trying to build clinical rapport, right? You're giving the clinical data, and they're like, yeah, but this is my homeboy, this is my family member, whatever. That it gets back to that like highly aware, highly observable work through. They're a person first, right? They're a person with an ailment, not an ailment, with a person attached to it. So like tackle like that, and you're always going to be better, right? Whether they're telling you what was previously done or, what they don't want done, which could, play the opposite side. But yeah, that's just being a clinician, right? You're not just a hammer, going in there, but you could still have every clinical skill in the world and be the worst practitioner in the world because you don't know how to apply them. You don't know how to, pick up social cues. You have no empathy, bedside manner. Yeah. So you got to have it all.
Yeah.
To what
then
level?
You should probably just be a surgeon.
Well, and you said earlier about you'd want to be with, somebody in the medical field that's just like world-class at diagnosis. So I still remember we listened to Dave King, who's, I would say, in the top 5 hip surgeons in the world, in particular with osteotomies and labor and repair, at a DNSC course at Brett Winchester's place. And somebody asked me, like, why are you so good? And he goes, I'm a messy carpenter in terms of my surgical prowess. It's my diagnostic capabilities. So it's basically who I put in the surgery suite determines my outcomes. And then he went through, and I was like, yeah, that's like, did everybody hear that? Like, let's hone in on what he just said. Like, he's still a really good surgeon, I'm sure, but he doesn't think he's world-class surgeon. He's world-class diagnostician, which makes him, therefore, a world-class surgeon. So, yeah.
In terms of outcomes, exactly.
Yeah.
Yeah. To me, it all comes down to diagnosis. To go back to the basics, I think that like what a lot of people are missing today is specificity and diagnosis, and a lot of that comes from the positive of pain science is that we're now paying attention to the psychosocial factors with great detail. The unfortunate consequence is that at the same time they were emphasizing this is that they were intentionally de-emphasizing biology.
Yeah.
And that didn't need to happen. It's a little bit like I was watching a podcast the other day from Trigonometry. I don't know if you know them, but not in our realm at all, but not trigger points at all, like just like triggered. But they were referring to basically, I just totally lost my thought. I should have eaten before this. I'm going hypoglycemic here. Where was I going with this? Help me out.
I don't know. Something on the realm of, we were talking about being a good surgeon based on your diagnostic prowess. All goes back to diagnosis.
Oh yeah, general and specific. I think I just totally lost it.
You're good.
The point I was trying to make was that if we don't see it, we can't possibly determine that there's no usefulness in implementing that potential intervention that addresses that parameter in a patient's outcome. And so we just need to make sure that we're paying attention to things. So, identity politics. That's where I was going with this. They were talking about identity. They were talking about identity politics. And the one guy's point was that the problem with identity politics is that the more you emphasize one specific group or people that have a certain identity, you actually are de-emphasizing all these other people over here and you alienate them. Mm-hmm. And by virtue of alienating them, then you create opposition.
Yep.
Instead of just saying, for example, the example that he's giving is that everyone should just have equal rights and privileges. Everyone should be treated equally. Instead of saying these people should have more. And the other person was not on that boat, but that's fine. My point is that we shouldn't have identity politics in our biopsychosocial interventions. We should just be looking at the whole system and not de-emphasizing biology or the biological mechanisms or the nociceptive mechanisms or the biomechanics or the posture or none of it. We shouldn't be de-emphasizing this bucket just because we're paying attention to the psychosocial realm.
Yeah,
right?
Additive.
Like this is where what we do is so fascinating and amazing. It's the reason why we can learn throughout our whole careers, because we actually need to be good at all of it. We actually need to be good at addressing, function,
Mm-hmm.
basic human function. And we also need to be really good at understanding the psychological and the social influences of a person's, presentation on their pain presentation. So,
Infinite game for sure, man.
yeah.
Well, A, I can't thank you enough for doing this. B, I do hope we get to meet in person sometime in the near future. And maybe I'll take a course from you, or, we'll have you come down and teach in Nashville or something. Yeah. Any last words? I mean, we've hit on some really good, like we've been repetitive in a good fashion, right? We've hit on notes that we keep coming back to. And anytime that happens, I mean, that's the important pillars of, I would say, how you practice, but then hopefully what we see a little more proliferated within our profession. But any last words before we jump off here, man?
No, I think I've talked enough. I hope people got something out of this.
Oh, 100%.
Yeah. Yeah.
I know they will. And the best thing is you can go to any of the courses that you're an instructor for or that exist in our realm and learn specifics. I think what we actually need at this point in time is better generalized frameworks for how to become a good clinician. Right? You can have all these tools. You still have to create a workable heuristic. And I think that's what you hit the nail on the head of today is like, well, what are the bigger pieces that I can go back to, right? Some sort of review process, being aware, caring about the patient, reviewing my notes, these are just core things. This is like, clinician 101. Well, don't go to 102 until you've hit the 101. And I mean, that's, now my editor is probably going to call this that, but yeah.
Can you think of a continuing education course that you could go to and come out of it after 2 days and be an expert on that topic or that skill set?
Funny. No, I don't. But in every state, for some reason, it seems like you could at dry needling, the way every state approached it in the U.S., which is kind of interesting.
Sure, but that's not reality.
Right.
That's what they're, what my point is that you go to a course to pick up a skill set and get really rudimentary competence in that skill set or, knowledge set, whatever you're focusing on in that course. You need to have that time in your week to review and practice and study and work on it. It took me, this is super fortunate of my background in hosting courses, but I would go to courses 10 times and I still would be like on the 7th time through, feel like I'm learning a lot.
Mm-hmm.
And a lot of people will go to one DNS course and be like, yeah, I got it. They'll go to one neurodynamics course and be like, yeah, I got it. But if you actually quiz them, you actually ask them to show you like, hey, show me supine 3 months, or hey, show me this, or you ask them some kind of a more complex clinical reasoning question based off of that content you just taught them. They can't put it together. They can't demonstrate high level competency in that clinical skill. So we need to have a routine in our daily life where we're reviewing and practicing and growing the skill set. So if you go to a course, you come out of that course with reviewing it. I actually think that's a huge strength of the new way that we're teaching neurodynamics with the hybrid model is that you do all of the theory for 2 months before the in-person course. The in-person course is going through all of the clinical skills along with some clinical dialogue. I can't help myself in bringing up clinical cases when I go through that. And then you have access to that content it's 1 month before the course and 2 months afterwards, I think, or vice versa. But you have 3 months total access. And a lot of people will talk about, it was really helpful to have access to the videos of the skills after the course because listen, how often do you perform a fibular neurodynamic test?
Yeah.
Maybe once a week.
Yeah. Depending on your case. Yeah. Population by.
Right. Yeah. Depending on your,
runners,
practice, if you don't have a very spine or neuro focused practice, you're probably not performing some of the more specialized neurodynamic tests every day or multiple times a day. So you kind of need to review that skill. And I still will go into some patient interactions. It's just like a busy week. And I'll be like, okay, I'm going to do the fibular neurodynamic test. And I have to take a double take on where I'm going to put my hand placement.
Yeah.
You know what I mean? Like, so, and I've done it a freaking thousand times. Maybe I'm just slow,
Yeah.
right? Maybe I'm just slow. Maybe I'm just not picking up on these clinical skills as quickly as I should. Maybe I'm not studying enough. But the point is that we need to be constantly reviewing even the basic skills.
Yeah.
Even
Maybe,
the,
yeah.
like, you know,
Cool.
have you,
You'd
have
be
you ever seen,
reviewing basic sciences too. I mean,
have,
that's, yeah.
yeah, have you ever seen Dave Traster do a neuro exam?
Mm,
If you watch him do a neurological exam, you're like, oh, I don't know how to do
I'm the
this at
worst
all.
in the world.
Yeah, like I
But
I mean,
you need that in all realms, right?
yeah,
Not just clinical, like life in general. I mean, like we worked a triathlon this weekend, and then you think you're kind of like, oh, I'm pretty good at something. Then you watch somebody world class, you're like, oh yeah, like yeah, that's what that is. Like
yeah,
humility. Yeah, yeah.
yeah. It's like watching Pavel do an elbow exam, and you're like, oh yeah. I'm not getting that kind of information from that.
Well, cool,
Yeah,
man. Well, I have to go see patients and put all of the stuff we just talked about into practice. But again, thank you so much for taking the time. And yeah, if you're not familiar with Michael Maxwell and what he does, we'll have links to continuing education and the articles that he writes, which are just a trove of knowledge in general. So thanks again, Michael. I appreciate it, man.
thanks guys. Take care.